Hi there, I'm Dr. Mike Smith. Great to have you here with us today. We're going to be talking about how to successfully complete a liquid nitrogen spray cryotherapy procedure. The first step in any successful cryotherapy procedure is to do a routine diagnostic endoscopy. Why is that important? Well, first, we need to look for any potential contraindications to cryotherapy. Those could include significant ulceration or mucosal disruption, altered anatomy that precludes safely placing the cryotherapy-related equipment, or significant food in the stomach. And second, we need to get an accurate location for the esophagogastric junction with respect to distance from the incisors. That's important because that will allow us to effectively and accurately place the cryotherapy decompression tube, or CDT, for use during the ablation procedure. It's very important that everyone understands their roles and responsibilities during the procedure. The physician's job, of course, is to keep an eye on the patient and to work with anesthesia to make sure that the patient remains safe and comfortable with stable vital signs throughout the duration of the endoscopy. Someone needs to be at the console, and someone else should be having their hand on the abdomen of the patient to make sure that no distension is encountered, especially while applying the cryotherapy. A guide wire can be used to successfully place the cryotherapy decompression tube, or CDT, at the time of diagnostic endoscopy. If you're using a 16 French CDT, at least one of the 4 black bands should be above the esophagogastric junction at the time of successful placement. And this can be confirmed on relook endoscopy before cryoablation has begun. If you're using a 20 French decompression tube, the 2 black bands should be at least 1 centimeter beyond the treatment zone. And again, this can be confirmed on relook endoscopy. One thing you can consider is placing a distal attachment cap onto the scope. You want to look to see where the hole is and that it is not going to be covered up by the endoscope once it's placed on the tip. Next, you'll want to re-intubate the patient with the endoscope to make sure that the CDT is in proper position. We can scan the catheter for use. At this time, you'll want to remove the catheter spring introducer from its pouch and place the tapered end about 2 centimeters into the biopsy cap of the endoscope. Depress the gray suction foot pedal and then press the defrost button on the user interface. At this time, you'll want to place the ablation catheter through the introducer and into the working channel of the endoscope. Always remember to have someone monitoring the abdomen for distension while you're in defrost mode. Now we're ready for cryotherapy. This particular case is centered around a patient with benign disease, like Barrett's esophagus with low-grade or high-grade dysplasia. In these cases, we typically use a dosimetry of 2 cycles of cryoablation or 3 cycles of cryoablation, each lasting 20 seconds. Once we've determined the first ablative zone, the catheter will be placed about a half a centimeter to a centimeter above the targeted area, and then we'll start to spray until the entire target zone is frosted white. At that point, we'll start the timer for 20 seconds and continue to spray, moving the catheter back and forth in a painting motion. That will keep the entire area frosted over. Once we've completed the 20 seconds, we'll let the targeted area thaw. This typically takes about 60 seconds, but we'll look for visual confirmation before repeating the entire process. At the end of the thaw, this is what we want to see. No more ice or frozen tissue, and you're starting to see that hyperemia, or what ultimately becomes a beefy red appearance to the treated disease. Liquid nitrogen spray cryotherapy is also indicated for use in malignant disease like esophageal cancer. In these patients, we typically use a dosimetry of 3 cycles of 30 seconds for each zone. A target zone in malignant disease, again, is defined as no more than 2 by 3 centimeters in surface area, and perhaps less based on the bulkiness of the disease. Once we've identified the first treatment zone, we place the catheter above that site and start to spray until the entire area is frosted white. At that point, we'll turn on the timer for 30 seconds and continue to spray, moving the catheter back and forth in a painting motion. It's particularly important to watch the treatment zone during these 30 seconds in malignant disease. Due to the amount of angiogenesis, reperfusion is faster in cancer, and so we need to make sure that that entire treatment zone remains frosted for the full 30 seconds of treatment to get the desired effect. Once we finish the 30 seconds, we'll turn off the cryoablation and let the targeted area thaw. This typically takes at least 60 to 90 seconds, but we'll look for visual confirmation before repeating the entire process at least 2 more times, with duration and number of cycles at the discretion of the treating physician.